So I'd like to welcome you all here today, and thank you so much for coming. I will have a brief introduction that will go through just some basic knowledge about Parkinson's disease, and then we'll move into drug therapy. So if you have any questions, I'd be happy to answer them after our presentation. So let's get started. So we know that Parkinson's disease is actually pretty common. As many as 1 million Americans will actually live with Parkinson's disease, as I will abbreviate PD. About 60,000 Americans are diagnosed each year, and the mean age of diagnosis is about 65 years old. However, we know that people are diagnosed much earlier than that, as evidenced by Michael J. Fox, etc. Men and women, men are affected a little bit more so than women at about 1.5 to 1. When you look at direct and indirect costs that people are paying out of pocket, or society is paying out of pocket for the treatment of Parkinson's disease, it's about $25 billion per year. Medication costs on average are about $2,500 per year, and therapeutic surgery can run up to about $100,000 per patient, and that just depends on which particular procedure you're having or not. Now, we know that Parkinson's disease contributes to motor dysfunction, and that's the clinical symptomatology that we see. We know that it's caused by a loss of dopaminergic releasing neurons, generally in the substantia nigra. However, many other structures in the brain may also be affected. Ultimately, it reduces movement or slows movement, muscle control, and balance. We also hear about Lewy bodies, and Lewy bodies actually are abnormal aggregates of proteins inside the nerve cells, inside a PD nerve cell. We know that that actually happens in the brain, and that can actually cause dementia in some patients, but we also know that there are Lewy bodies that form in the gastrointestinal tract as well. When you think about the motor symptoms, we always go back to the acronym TRAP to remember the clinical symptoms that we may see with Parkinson's disease. T, the tremor that some patients have. Most patients will have a tremor component, but not all patients will have tremor. And that's usually a fine pill rolling tremor, generally present at rest. There's also rigidity that occurs, which is basically like a cog-wheeling feeling at the joint intersection. We also know that there's poverty of movement, or bradykinesia, or akinesia. Akinesia would be a without or loss of movement. So that can actually be a slowed type movement or poverty of movement. We also know that postural instability can also be problematic. Now, many patients will have the postural instability maybe a little bit later on during the disease course, and that leads to a gait dysfunction or impaired balance. So we know that many people with Parkinson's disease will have a simian stoop, so they'll bend a little more forward at the waist and have a shuffling gait later on. But we also know that there are non-motor symptomatology that goes hand in hand with Parkinson's disease. So many patients can have depression or anxiety, and that actually can be a presenting sign that may go unrecognized in patients. So that may be just an early presenting sign. Olfactory dysfunction is poverty of smell. And we're finding more and more evidence now that that actually may be the very first presenting sign of Parkinson's disease. You can also have some drooling, you can have hallucinations, you can also have some dementia that occurs, especially due to the Lewy body formation in the brain. We also know about the autonomic dysfunction. So how many people here have a lower blood pressure than they used to have? So that would be an autonomic type dysfunction. So we have to watch when we're prescribing our medications, our dopaminergic medications for Parkinson's disease, because we know that those medications can actually lower your blood pressure in addition to what your body's already doing because of an autonomic dysfunction. And obviously, when we have lower blood pressure or problems getting up from a chair, as we call orthostatic hypotension, that you can actually feel that lightheadedness or dizziness when you get up too quickly from a chair or from sitting to standing. You also can see excessive sweating. You can have loss of bladder control for some individuals. You can have constipation, so things slow down. So we talked about that poverty of movement or bradykinesia. That also could just be slowing everything down, especially in your gut. So that can cause constipation in patients with Parkinson's disease. So medications, we know that there are a handful of medications that can exacerbate or maybe make Parkinson's worse in some individuals. So we know that Parkinson's disease is kind of a lack of dopamine. And that's an oversimplification, obviously, because we're really talking about the receptors and the way we use dopamine. But as a general rule of thumb, as an oversimplification, we can talk about less dopamine being around. So medications that work on that symptomatology of dopamine, decreasing dopamine in the system, could actually cause the Parkinson's symptoms to exacerbate or become somewhat worse. So some of those medications are Compazine or Reglan can make the symptoms of Parkinson's disease somewhat worse. Also, some of the medications that we use to treat hallucinations in the brain can also make some Parkinson's patients worse. And that would be olanzapine or Zyprexa. Risperidol in some people, although we use risperidol on a regular basis to help some patients, but for some people it could actually exacerbate your symptoms. So as a first thing that we actually do is to look at medication therapy and make sure that a patient doesn't have something called Parkinsonism or drug-induced Parkinson's disease. So other medications that we also need to think about using in caution can be some of the blood pressure medications. Now, obviously, it's working on blood pressure, and you may already have a lower blood pressure because of that autonomic dysfunction. So in particular, the calcium channel blockers, because of their mechanism of action, may be a group of medications that we may look at to make sure that that is not causing some of your symptomatology of Parkinson's disease. And that would be like verapamil or nifedipine. Valproate or Depakote is a medication that we use quite frequently for mood disorders, so to balance out patients' moods. We also use that particular medication to prophylax for patients who have migraines. We also use it for epilepsy. So valproate or Depakote is actually a medication that we know in people that are about 60 and over can actually cause a drug-induced Parkinson's disease. So you actually see that rigidity in patients, generally people who are about 60 and older. You can actually, it looks like the patient actually has Parkinson's disease when it's really drug-induced, and that would be due to the valproate or Depakote. So now let's talk about the drugs that we have, and drugs and non-pharmacologic agents that we have to treat Parkinson's disease. We know that non-pharmacologic agents can be surgery, speech therapy, or is oftentimes coupled with drug therapy. Exercise is so important. I think of all the disease states out there. And we know that exercise is so important for everybody, but in particular, patients with Parkinson's disease. It's really important to keep those limbs and the joints exercised and moving regularly. Education, support is also very important with Parkinson's disease. When we look at our drug therapy, we kind of chunk them into different groups, and we'll talk about individual drugs that fit underneath each one of these pharmacologic classes, such as the dopamine replacement agents, dopamine agonists, COMT inhibitors or catechol O-methyltransferase inhibitors, NMDA receptor agonists or N-methyl diaspartate receptor agonists, anticholinergics, MAOB inhibitors. So this is basically a slide or a cartoon of drugs that would fall under the category of dopamine replacement. So we're really talking about Sinemet therapy. We're talking about Carbidopa, Levodopa, so a combination therapeutic agent. So we know that it comes in many different flavors, right? So I'm sure that we have some people here that are on Sinemet therapy, and we know that it comes in many different tablet strengths. We also know that it comes in a controlled release preparation, and we have an extended release preparation that is a generic product of Sinemet. So Carbidopa, and why do they live together in the same pill? Well, Carbidopa will actually stop the conversion of levodopa to dopamine in the periphery or outside of the brain. So it actually kind of acts as a carrier molecule to take the levodopa across the blood-brain barrier, where you can actually break it down and use it as dopamine. We try to not, and it's kind of a fine balance when we're starting carbidopa, levodopa, because we want to make sure that we actually have enough carbidopa in the system to saturate what we call dopa decarboxylase inhibitor receptors, which are responsible for the breakdown to dopamine. Because if we break too much of the levodopa to dopamine in the peripheral system, we actually will see that you cause a lot of nausea. So it's really important to have that balance of the carbidopa in addition to the levodopa to make sure that you don't get a lot of that nausea and vomiting. Now, in some patients, it's a little tricky. Some systems are a little more sensitive than others. So we may actually prescribe a little more carbidopa in addition to what you're already getting in the carbidopa, levodopa. So what are some of the side effects that we see with carbidopa, levodopa? Well, nausea and vomiting, as I've already alluded to. And it used to be that that would be very problematic before we figured out to put the carbidopa with the levodopa. You can also see orthostatic hypotension. So again, decreasing your blood pressure, all right? So we have to be careful and make sure that we're monitoring your blood pressure when you're starting this medication. You can also see some discoloration of the teeth, urine, and tongue with this particular medicine. And motor complications that are long-term with levodopa, carbidopa are something we call dyskinesias. So dyskinesias are actually unwanted movement that generally happens in the upper trunk. So the arms and maybe the head. You'll have unwanted movement when you don't want it. There's also something called on-off phenomenon. An on-off phenomenon is kind of like a light switch. So that just means that you will have moments of being very on and able to move really well, and then moments that you're frozen. So the Parkinson's disease or off periods would be back. We know and we monitor for these particular side effects on a regular basis. So this is basically just, as I'm looking at this little cartoon here, this is talking about the nausea and vomiting with carbidopa, levodopa. And we've kind of already talked a lot about this. But one thing that I do want to mention, aside from the nausea and vomiting, is the fact that you want to increase this medication slowly in your system. You want to try and maybe take it with a small snack when you first start taking the medication, but you want to avoid large protein meals, because what we see with carbidopa, levodopa is that you inhibit its absorption in the gut with a high protein meal. So protein actually competes for the absorption of carbidopa, levodopa in the gut. You can also try and take it with carbonated beverages. It might be a little bit easier to take for some people. And if you need to take extra carbidopa, you can actually do that if need be. This is actually just a little diagram that I like when I talk about the on-off phenomenon and dyskinesias. So with the on-off phenomenon, as you can see, you move and you're kind of moving to the on period after you take your medication, and then it drops off and goes to the off period, where you start to see that freezing or more of the Parkinsonian symptoms coming back or Parkinson's symptoms coming back. So in this bottom box, we actually see this is the off period. That's where patients actually have more of the Parkinson's features. You're well controlled in the middle box, and then you have dyskinesias when you're in the upper box. That's where you have the unwanted movement after taking carbidopa, levodopa. So one way that we combat this, if people have on-off phenomenon or dyskinesias, we'll oftentimes try to use a lower dose of the levodopa, carbidopa more frequently. So you might take the total daily dose that you're on and chunk it up and take it more frequently, as opposed to having a big peak and a low trough. Hence the on dyskinesias and off more of the frozen state. The other thing that you can do is decrease your levodopa by increasing a dopamine agonist or adding a dopamine agonist to the regimen, such as Mirapex or Requip, or the Nupro patch. Nupro patch, the beauty of that design is you're keeping more in that well-controlled zone, so you don't have high peaks and low troughs. You also sometimes can see amantadine paired to decrease that fluctuation or those unwanted dyskinesias. Now we have a newer kit on the block that's actually called Duopa, which is carbidopa levodopa, but it's a different formulation and release. So it's really a suspension type product, and it still has carbidopa levodopa in it. You actually administer it through a cassette and a J tube or a PEG. So it's a tube that goes into the gut and releases the medication. And it's a 16-hour infusion period. We also have another new kit on the block. So this is called Ritari. And Ritari is actually an oral capsule that's extended release. And usually when we have an extended release preparation or product, it's usually the overlay on the capsule or the tablet that makes it extended release. But this is a little bit different because it's actually the spheres inside of the capsule that make this particular product extended release or last longer in your body. So the beauty of that is you can actually pull the capsule apart and sprinkle it on food. And so there, if it's hard to take things orally, or you just want a better way, an easier way of taking the preparation, you can actually pull the capsule apart and still maintain that extended release intended property of the drug. Our other extended release preparations, most of the time you can't cut, chew, or crush. I will say that with exception of Sinemet. So the continuous release preparation, we can actually cut that particular medication, but that's generally not the rule of thumb with other extended release preparation. So the dopamine agonists are used to treat Parkinson's disease, and you can use it by itself, or you can use it in combination with Sinemet therapy or carbidopa levodopa. Again, we have many different preparations. We have an extended release preparation of each one, and we have regular immediate release preparations of ropinirole or Requip or Primapexole or Mirapex. And then we have the rotigotine patch. And the rotigotine patch is pretty handy for many people because you slap the patch on, the heat from your hand is going to activate the adhesive of that particular patch. But it's going to allow the medication to be released over a gradual period of time of about a day. And it comes in many different milligram strengths as well. This is basically an example of where we can actually put the Nupro or rotigotine patch. So there are many different sites on the body, and we ask patients to actually rotate those sites and not use the same site, if at all possible, for 14 days. The side effect profile that we can see is we can see a lower blood pressure or that orthostatic hypotension, and that's with all the dopamine agonists. Again, we need to monitor for that and be careful. You can see some insomnia, so it might be hard for some people to actually get to sleep because dopamine, when we think about it, is really a feel-good neurotransmitter, and so this may actually give us a little oomph or a little, just a little energy. You can see some dyskinesias, confusion. You can also see hallucinations for some people, and we need to monitor for those and treat if they occur. You can also see something called sleep attacks. So you can actually have sudden sleep attacks that can occur at any point in time with the medication, and that's an important point, and if that's occurring, you need to talk to your physician or your healthcare provider. And up to 14% of people actually have had a devastating side effect, which we consider a compulsive behavior. So many people, now it would be a problem with me because I really like to shop, so that's a big deal. So I would be one of the people that this could be very devastating because I don't really need any help of a dopamine agonist to make me spend money on shopping or clothes. So it's important that your healthcare provider should be asking about this particular side effect. So it can show up as increased gambling. It could be sexual relations with somebody else, etc. But it really is a devastating side effect, and we've seen it really have problems or ruin people's lives. So it's important to monitor for these particular side effects, and also tell your significant other or next of kin, whoever happens to be, someone that's in your life, to monitor for these particular side effects. Now, apomorphine is a rescue type medication. So apomorphine is used for freezing episodes. So it's an injectable preparation that you take if you get stuck or frozen. So we know that with this particular medicine, it's a dopaminergic type agent, it can cause a lot of nausea and vomiting. So we usually have patients pre-treat with Tygan about 3 days prior to initiating this particular therapy. So it protects against the nausea and vomiting. We also have monoamine oxidase or MAOI inhibitors such as selegiline. Rasagiline would be another agent that fits in this class. And these particular drugs really work by preventing the breakdown of dopamine and prolongs the effect of levodopa. So it improves your Sinemet type therapy. So the side effects that we see with the MAOIs, now in MAOIs, and I don't want to go into a major pharmacologic discussion here because we could talk a lot about the difference in MAOIs because there are MAOAs and Bs, but we're not going to get that detailed. Some of the other type medications were used for blood pressure and could have more side effects than these particular MAOIs. So side effects or adverse effects that we see with the MAOIs, so selegiline or rasagiline in combination with some of our SSRIs or drugs that we use for depression, serotonergic reuptake inhibitors, such as Lexapro or Paxil, fluoxetine or Prozac, etc. Some of those medications, if you're taking larger doses of both, you may actually see that your blood pressure can actually go up and can cause some sweating that can be problematic and even life-threatening. So we always try and counsel patients on what we call the serotonergic syndrome, which is very, very rare, but should still be counseled upon, and patients should still be on the lookout for them. Tricyclic antidepressants are commonly prescribed with the MAOs. Tricyclic antidepressants such as Elavil or amitriptyline, nortriptyline, etc. So there's something that also lingers in the package insert and oftentimes with the piece of paper that sometimes your pharmacist may give you with your medications, and that's called the tyramine effect that you can see with these particular medications. It can actually cause a dangerous increase in blood pressure, However, I will say that this is really a rare side effect. And pretty much it has been dispelled from the MAOI, so rasagiline or selegiline. We never really see this side effect. The companies have actually done research with rasagiline and found that it's probably not an issue unless you really overdo it, and you'd have to be overdoing it. Overdoing it on your dried sausage, maybe, okay? So I kind of like that kind of stuff, even though I shouldn't admit it. Soy sauce, we're talking about a lot of soy sauce, like a whole bucket of soy sauce. Talking about lots of it. We're talking about fermented cabbages, probably not eating a ton of that. I don't know, maybe. Cured meats and some of the aged fish, like pickled herring. And I'm not sure, does anybody eat a lot of pickled herring? Some, but not a lot of pickled herring. Just a little, little's good. Everything in moderation. But it's really not an issue. And actually I remember I was actually getting my nails done, okay? So just one of those little pampering type things. And my, the nail lady that I go to, her mom comes in and says, "Can you look at this piece of paper that the pharmacist just gave me? How much tyramine is in a piece of Swiss cheese?" And I'm like, "What?" I don't know how much tyramine is in a piece of Swiss cheese. And so at first when these drugs came out on the market, they were all about don't eat any of this stuff because you could potentially have this reaction. But it's really, it's very, very rare, and you'd have to eat a whole lot of it to have that particular reaction. So don't be afraid if somebody gives you a piece of paper that tells you, don't eat the Swiss cheese, etc. We also have COMT inhibitors. The COMT inhibitors COMT stands for catechol O-methyltransferase inhibitors. And basically, these particular medicines help to reduce the wearing off effect. So these medications, like tolcapone and entecapone, tolcapone is not used because of the side effect profile of that medication. However, entecapone or COMT is used. And basically, these drugs don't work by themselves. They actually increase the efficacy with Sinemet therapy. Okay, so no efficacy on their own. They're only working in combination with Sinemet therapy. So as I mentioned, tolcapone is not really used so much anymore. It is available. However, the side effect profile makes it a second-line agent of this category. You can see a lot of diarrhea with tolcapone. You can also see liver damage with this particular medicine. So it's only used, again, as a second-line agent behind entecapone because entecapone has much less side effects than tolcapone. Now, speaking of combination products, entecapone you will find with Carbidopa, Levodopa in the combination product called Stalevo. And there's varying doses of Carbidopa, Levodopa. Entecapone stays stable at 200 milligrams. However, you will see that the Carbidopa, Levodopa changes in each one of these different pills. Amantadine is also used to treat mild symptoms. Well, we know it can help with our dyskinesias, the unwanted movement, smooth some of those out for some patients. We also know, however, that amantadine has a mild dopaminergic effect. So in some patients, when you're newly diagnosed, you may actually start with this particular medicine if you have tremor as your predominant feature and your main feature, or some rigidity with this particular agent. So it's a first-line agent if you only have mild symptomatology. You only see a modest effect, and usually we talk about this drug as being a drug that loses efficacy over time for some people, not all. So we generally bank on about a year of good benefit from this particular medication. However, the benefit is generally modest at most. Some people may have a better effect than others. So then we have drugs that we call anticholinergics. So anticholinergics could be artane or trihexyphenidyl. You can see cogentin or benztropine or Benadryl or diphenhydramine. The anticholinergics can actually be helpful with tremor. Again, so if you have predominantly a tremor predominant PD, then anticholinergics may be the initial place for patients to start therapy. Can also help in combination therapy with your dopamine agonists for drooling or siluria. The side effects, however, though, as you see this cute little, oh, there's a bat, and it's October, so it's we're right on cue for Halloween. So basically what you can see is that the anticholinergic side effects that we always talk about is everything dries up. So you have urinary retention, so you can't pee. You have constipation, so that makes those things more difficult. You can have a dry mouth. You can also have flushing and blurred vision. Non-motor symptoms that can be treated and are often treated with Parkinson's disease are, and we've talked about these early on, are mood changes or cognition changes, attention and memory problems, the sexual function or dysfunction, and problems with the gut. And also fatigue and sleepiness, which we know can be very problematic in patients with neurologic conditions. Also, you can see the depression piece. So depression and anxiety, we generally will consider a serotonergic reuptake inhibitor, or SSRI type medication, like Zoloft or Lexapro, Celexa. Hallucinations, generally what we'll do to combat those side effects is the first thing is to lower the dose of your dopamine agonists. Sleep issues, generally we know that Parkinson's patients have lower levels of melatonin. So melatonin replacement is the first place we'll go if people are having problems sleeping. Diphenhydramine can be, Benadryl can be helpful for sleep. Ambien or any of the other drugs used for sleep can also be helpful. And we also know that restless leg syndrome can affect about 20% of patients with Parkinson's disease. So many of our medicines that actually treat Parkinson's disease will also help with the restless leg syndrome, although we're seeing now that there might be a problem with augmentation in the RLS folks. So sometimes we try to use other medications, such as a group of drugs that comes from the alpha-2 delta ligand group, such as Horizont or gabapentin and acarbil, or just general gabapentin, et cetera, to combat some of those symptomatology. Herbal supplements, there's been a lot of research that has actually gone on with CoQ10. Bless you. So CoQ10 has actually been found to be probably not effective in Parkinson's disease. It might be helpful for other problems. So statins for high cholesterol, it works really well for those leg cramps that you get with statins for lowering blood pressure or lowering cholesterol. We also looked at creatine. And I was actually part of both of these studies, and some of you in the room were actually part of some of these studies. So creatine looked pretty positive initially when we were screening compounds for the treatment of Parkinson's disease and halting the disease progression, so as a neuroprotective agent. However, it was found to not be significant in the Parkinson's population. I'm not sure if we had the right patient population that we were actually studying, because I think that there's probably different variants of Parkinson's disease, and so maybe if we were a little more keen on figuring out the different subtypes of Parkinson's disease, maybe we would have seen a more robust effect with creatine in those early clinical trials. There's also a lot going on in the pipeline for clinical research. So we know that they're looking at stem cell transplants, et cetera. There are other new drugs that are also coming out on the market. So I thank you guys for your attention. Does anyone have any questions? Lots of questions. Okay, let's start here. I think you're first.
I was going to ask you about the injectable drug that you were talking about.
Apomorphine?
Yeah, I have it
Yeah.
here somewhere, but yeah, I guess that was it. So my question was, how often and what does it replace?
So apomorphine, the question is, how often would you use apomorphine? And so basically that's just a rescue medicine. So you would use it if you were someone that was trying to cross the street and you'd be frozen and nothing else would work. So none of the mind tricks that we often talk about work. So at that point in time, then you would use the injectable apomorphine to just move on.
Earlier you spoke of the injectable.
Oh, and the Duodopa.
Yeah.
Yeah, so that particular medication actually is a continuous infusion. It's driven by a pump, and it goes into the gut through a tube, a J tube. So it's all the time. It's a 16-hour cassette infusion. So yes.
Why would somebody do
Well, if you can't take oral medications,
so it's not
It's-
good.
it's usually seen later on. For some people, not for all people. Yes.
Given the dizzying array of choices, side effects, and drug interactions and all this, what role can or should the person with Parkinson play in choosing a new drug other than reporting side effects or reporting effectively nausea? I've never seen ads saying, ask your doctor if this is right for you, but in a sense, with all this information, what do you do with it in interaction with your neurologist?
Right. So good question. Like with all this information, sorry if I overwhelmed y'all. It's actually good to have options, right? Lots of things to choose from. So basically, what do you do with all that information? Well, I think basically just knowledge about the side effects that potentially some of the medications can cause, and having an open discussion with your physician or your pharmacist about those side effects, and seeing what other problems that you might actually have. So concomitant disease states that you may have in addition to Parkinson's disease, and try and pick and choose the medication that's best for you based on the side effect profile for the medicine.
It seems to me it's up to the neurologist who's going to know better the details, no matter how much information you ingest.
Yeah, so as the patient, you can always say, I've heard about this particular side effect. Are you sure this is the right medicine for me?
Is the safest thing to avoid all of those non-motor side effects?
Yeah, so it really is going to be what's the safest thing to avoid. I think it depends on the individual, and you're right. We generally tell people to stay away from Benadryl, but for some people, a little bit can be helpful, but for other people, it's not. So it's one of those medicines that we do tell people to avoid. So it just really is picking and choosing, and sometimes it means that you're trialing and error differing medications, and people become very sensitive. I'm a person that's really sensitive to medication side effects. A little goes a long, long way, and it's hard to convey that to many people. So I also think the least effective dose of any medication is where you need to be. So just because we know what the normal dose is of a particular medication, doesn't mean that that's where you absolutely have to be. I think that warrants a conversation with your healthcare practitioner in Duke. Yes, I didn't, but we do use Seroquel.
Why would you use one versus the other in terms of the zone versus
So they're different. Seroquel would be used more for the hallucination type piece, whereas Lexapro would be used more for depression type. So again, Seroquel is probably our go-to medication for hallucinations because we find that it causes the least amount of problems in some people. But again, it's going back to the lower dose.
more dominant, and hallucinations don't bother the patient?
Right. So then you'd be better with the antidepressant kind of thing. So right back there in the corner is the farthest point.
Different thoughts on dementia, memory medications, and Parkinson's.
Right. And the question is about the medications that are used for dementia in Parkinson's disease. And so, there are differing schools of thought on that. Sometimes they're used and just sometimes they're not. So you have to go back. Sometimes it just depends on the person. So is it happening early on? Is it not? Are there a lot of Lewy bodies, et cetera, or thought to be? So it depends on the person. So a super young person, that maybe that's one of their presenting signs, then sure, they're probably going to start. Your practitioner might start there, and which one you choose, probably it would be Aricept as your first starting point. That may be helpful for some individuals, and it might not be helpful for other people. So it just depends on the individual case scenario. Yeah.
And is there a length of time that is beneficial, and then after a length of time you stop?
The question is there a limited amount of time as to when or how long those medications are useful for? And we generally see, again, varying effects in individuals. So you do see that their efficacy, you might have a year, you might have 5 years. It just depends on the individual person. And I know that's not a lot of concrete information. Unfortunately, that group of medications, you just don't know. You hope for the best, and maybe try, trial and error different medications from that class. But it's really a trial and error type thing. I think yes.
You said the CoQ10 hasn't proven anything, so what about glutathione?
So the question is, what about glutathione? Because we know that CoQ10 is ineffective. Glutathione, I personally have not studied glutathione. I think glutathione is interesting. I think, I'm not sure. There's no proven evidence for glutathione that I'm aware of. Pardon?
Tell us what that is.
It's a nutraceutical or natural type product. So looking more at the cell powerhouse of the cell, which I think is actually important in Parkinson's disease. And that's where we were kind of working, and I can say we because I was actually part of this. But that's what we were actually thinking with the creatine. So there are different ways of thinking about halting disease progression and being neuroprotective. So that could actually be at the cellular level, or it could be at an anti-inflammatory level. And so that would be more directed at the cellular level. I think as long as you're not overdoing the dose. I mean, I can't say yes or no because I don't know, honestly. It wasn't one of the drugs that screened that looked like it should go, to a bigger trial, but that just could be that it was something that was missed.
I heard that it's not available orally, that you can't absorb it orally, so they've been doing IV or injections. But I actually found a sublingual dose that I've been taking, but I don't know what I've been watching for.
Right. I would almost say with glutathione, if you want to give us your email address, we can give you some information regarding that. And I would just make sure you knew who you were going to and who was giving you the medication. So I do know some people are taking it orally, but again, it might be like throwing money out the window too. So we don't know. The sublingual also, I almost think that looks kind of interesting, but I'm not sure. I think probably one last question.
How does the Acerev work with the Sinemet?
So how does it work? Well, there are different mechanisms of action, and sometimes I like to, when I think about drug therapy, sometimes I like to come at drug therapy with different mechanisms of action. So it has some efficacy on its own, so you can actually use it as your starting medication for Parkinson's disease without any other medicine. However, you'll actually get a little more bang for your buck from your Sinemet therapy or your dopamine agonist therapy with with the Azilect or acetylcholine.
Okay, I think that we need to thank Dr. Bainbridge and wish her safe travel.
Thank you so much.